So we are now live on Facebook, and we have a few people who are also joining us. So we'll give them 1 more minute to join us, and then we will make a formal start to the proceedings. So I have muted everybody. This is how we shall keep it, and I will try and unmute people as you go along. Okay, so if our panelists and our moderators are happy to make a start, so just give me a thumbs up, so I know everybody is in place and in position. Fantastic. So we will be recording this session. So I'm going to start recording now. Okay, so I'm going to unmute Sadaf. And I'm going to unmute Mr. Sawal. Okay. Hi. So Assalamu alaikum. Hello, and welcome to our webinar. This is an APPNE webinar in the series of webinars we are doing for Yaran and Watan. Today's webinar is surgically orientated, and we're talking about the impact of COVID-19 on surgery. My name is Dr. APPNE. I am the president of APPNE, which is the Association of Pakistani Physicians of Northern Europe. We are a democratic organization based in Northern Europe with a massive base in the UK, Republic of Ireland, and contacts in other countries across Europe. We are working very closely with the government of Pakistan, especially with the Pakistan's health initiative, diaspora health initiative called Yaran and Watan. And these webinars are really a series, a part of the Yaran and Watan program. These webinars are going to be recorded, and they are also on Facebook Live. So if you do not want your face on the recording, or if you do not want your voice to be heard, please mute yourself and also keep your camera off. I will now pass on to my two colleagues who are moderating the sessions for today, and I will request Mr. Afzal Sawal and Ms. Sadaf Jafarboy to please come in now. Thank you.
Thank you very much, APPNE, and I'm Afzal Sawal. I'm the pediatric consultant, basically by trade, but I'm a pediatric neurologist. And I'm one of the moderator of this seminar. And as Amir said, that this is one of the series of the webinars which been conducted by on the platform of APPNE in collaboration with the Yaran and Watan. Today is a very interesting topic, immensely important not only in the UK but also in Pakistan, the impact of COVID-19 on surgery. And we are very pleased that we have got eminent consultant and speaker, not only from here, from England, but also from Pakistan. And we've been in this webinar throughout. You are most welcome to ask us any question, but the question is, please, after all the presentations, we will go to take up the questions, and all the appropriate, the presenter will go to answer all these questions. But please avoid asking question in between. You can ask question in the chat box, but we pick up the question in the end. So here we are. We're going to start our webinar, and I'm passed to the Sadaf, who will going to be introduced the first two speaker to you. Sadaf.
Thank you, Dr. Sawal. I'm Sadaf Jafarboy. I'm a breast surgeon and an executive member of APPNE. As Dr. Bernie and Dr. Sawal has already mentioned some ground rules for today's webinar. Without wasting much time, I'm going to introduce our first speaker, who is Mr. Naseem Waraj. He's a consultant colorectal and general surgeon at Walsall Healthcare NHS Trust, and he's going to talk to us about emergency surgery during COVID. Over to you, Dr. Waraj.
Dr. Waraj, if you can, I'm trying to unmute you from my end. Just hold on. I think there is a slight technical issue with, just wait, Naseem, I'm trying to unmute you from this end. There might be a slight technical issue from your end.
I think unmuted. So.
Yeah, that's fine. Thank you. Carry on.
Can you see my slides?
Yes, we can.
Okay, thank you so much. My name is Naseem Raj, and thanks for asking me to talk about emergency surgery services within the COVID-19 pandemic and how have we dealt with it during this unprecedented situation. I'll start with the important slide of the presentation, which is a conclusion of my slide, and just to reiterate that this is so highly contagious as well as deadly virus, and anybody can spread it, and anybody can get it. So since the first case was diagnosed in Wuhan in December 2019, it took 3 months for WHO to declare it as a pandemic, and it has now spread over 200 countries worldwide. We all know that it will stay there for unforeseeable future until we get some vaccination or proper treatment for it. Therefore, we have to adopt to a new normal to carry on with the life. And obviously, we are fighting against an unknown enemy, and which has disrupted whole of the world, actually, all spheres of life, including general way of life as well as the healthcare. It has affected general surgery as well, which include all specialties, and over 30 million operations have been cancelled worldwide, and almost 2 million operations cancelled within the UK. Of obvious reason, emergency services carried on, and we have adopted within the new informations available to us. And we all know that the informations are evolving almost every day on a regular basis. What we know so far that COVID-19, the mode of transmission is aerosols and droplets. And we know that aerosol stays within the room environment for almost 3 hours. And if they're on steel and plastic, they can stay there for almost 2 to 3 days. There's a recent paper in BMJ which has discussed about the viral shedding even up to 33 to 47 days after somebody is declared as COVID negative following the test. So this highlights how contagious and how contagious it is. So the whole aim to reorganize the surgical emergency services was to decrease the environmental contamination, i.e. in theaters or within the hospital, to minimize the exposure of the theater staff, to minimize the theater occupation, as well as to make sure the patient leaves the hospital after having surgery as quickly as possible. So American emergency physicians have had a tool called mass casualty incident, which has got 4 phases, which will help to understand the changes and precautionary measures we have taken to reorganize our emergency services to combat this pandemic. So we'll start with the mitigation. The government has really played a good role here to lessen the effect of it by saying stay at home and stay alive kind of campaign, which has not only flattened the curve, but also has had a good impact on the NHS afterwards, which my colleagues will discuss in later. So what we did, we segregated the wards to start with. We have separate bays. Initially, when there was a start of pandemic, not many patients coming in. All patients who were coming in with the symptoms were tested, and followed by every single patient who was in the hospital was tested for COVID-19. We made sure the appropriate PPE was available for all of the healthcare staff, and we also made sure the diagnosis doesn't get delayed, which eventually can delay in the further treatment. So after mitigation, we went to have some planning process where we plan to suspend all the elective activities, because we knew that once the pandemic happened, the resources may well be needed somewhere else. Like if 5% of people end up in ITU, they will need some more staff, and hence it was asked for the skillful surgical colleagues to be deployed there. Self-isolation and shielding has impacted the NHS generally, and almost 20% of the staff has affected by either self-isolation or with the shielding. We had to restructure the department in the form of rotas, theaters, and all the other things which I'll talk about in a minute. And the theater SOPs changed because electives were suspended and the only emergencies started in either trauma separate theaters or emergency general surgical theaters. In order to protect the environment, it was then thought that we must have a protected patient transfer. Patient should be having a PPE as just the mask only, and there should be a designated way and shortest possible way for transfer of patient from one place to other. I still remember in the start of the pandemic, when patient was being transferred from one place to other, the security people will come and just ask the people to evacuate the corridors. So all personal contacts who are transferring patient must have full PPE. We plan to use the disposable material wherever it was possible. And we have minimized the number of staff within the theater. We have made a timely entry and exit from the theater itself so that lessen the contamination. Personnel involved, they were not allowed to leave the theater, and we have got this. There are some studies which shows that in the laminar flow, there are 25 air exchanges can happen in 1 hour. And it has showed that after 5 exchanges, the environment get cleared up to 1%, basically. We also make sure the documentation is outside of the operating theater. How we responded to all these changes and plan, what we did, we have a consultant-led decision-making at front. We changed the rota, made 3 teams, A, B, and C. A was the on-call team, B was the standby team, and C team was just at home for a week time. And then that's how the circle carried on, so that we minimize the risk of people getting infected. If somebody gets infected, the standby team is available. As I said, to minimize the number of staff in OR, we have given them walkie-talkies not to come out of the theater during the procedure and things like that. We followed all the WHO protocols, and we made sure the patient, when transferred from the ward to the theater, goes straight into the theater rather than the anesthetic room. It's the intubation, extubation is regarded as an aerosol generating procedure. So every procedure was done within the theater itself. Once the patient is intubated, their face was covered with the plastic covering to shield it throughout the procedure. So, and for surgeons and the people, there was a separate donning area, which is pretty clean area and is separate from anesthetic area and else whole of the theater. It was, once the patient is anesthetized, it has been given almost 12 to 15 minutes for the air to clean from the air exchanges within the theater itself. Once the procedure is finished, the people have got to go separate through a separate exit door to a separate designated area where they get doffing and cleaning, and all the other measures are taken there. Patient then extubated in the theater itself and recovered there by the same staff. And then we have also made sure the secure transfer area is there for the patient to go to the recipient wards. It has caused a lot of delay because we need to deep clean the whole theater and whole premises after every case, and therefore the productivity for theater has gone really down. We also adopted some non-operative measures where possible, especially acute appendicitis. There is evidence that you can treat the acute appendicitis if it's not complicated with antibiotic. If it is perforated and peritonitis, in that case, you can actually you have to act and operate on it. Similarly, the other conditions where you can be treated conservatively, it was suggested to treat them conservatively. However, like hernias, which you can, if it is incarcerated, you can reduce it in a local anesthesia and then make it some semi-elective procedure. At the same time, some guidance came through from Royal College, which I can't find at the moment on the system itself. But the clear guidance was that to do the test for all people, do CT thorax at the time, and try to not to use the laparoscopic surgery. There was not much evidence available at the time. So initially suggested to do the open surgery, either as appendix or as laparotomy or whatever could be done should be done as open. And it was also recommended to have a stoma, not to anastomose, to minimize the complication and to expedite the patient discharge and minimize the length of stay. So in some certain cases, it was suggested to defer the surgery if possible within the pandemic itself, and to do a mass damage control surgery with open abdomen, although it may well be aerosol generating within the ITU settings. So I'll just touch upon this open versus lap at the time. Initially, we were doing all procedure open. Subsequently, as there was no evidence for the aerosol generation within the peritoneum itself, therefore, we started doing laparoscopic surgery in the middle part and at the later end of it. French people have started doing a trial to assess if there is any aerosol generation intraperitoneal or during the surgery. However, we have taken all precautions. We use surgical smoke filters, and some people do also suggest the laparoscopic surgery is safe because it provides the functional barrier. Currently, we are entering into the recovery phase, and there's a study published in Lancet, COVID Surge, which has given the directive was to carry on into the recovery phase. And my colleague will discuss in next few presentation about it. And we'll take all the questions at the end of the session. Thank you.
Thank you very much.
Thank you, Mr. Viraj. That was an excellent talk, and I can see some questions coming up in the chat box. We will address the questions once the talks are done. I would now like to introduce our second speaker for today's webinar. That's Mr. Amir Khan. He's a consultant general surgeon. He's an ex-medical director and responsible officer at Walsall Healthcare NHS Trust, and he's going to talk to us about restarting elective surgery and prioritization. Over to you, Mr. Khan.
Thank you very much for giving me an opportunity to talk today, Sadaf, and thanks to all our colleagues. It's quite an interesting topic, and I think my colleague before has gone through quite the details why we had to make the decisions, because when COVID hit the whole world, although it started in December, but by the time it came to the Western side, it was somewhere in March. At that time, as professionals, we had to make some decisions, and the decisions we made were not just out of hoof, but on mainly considering patient factors, workforce issues, and managing capacity. Naseem talked about some of them earlier, and when we looked at patient factors, the most important thing was the patient safety. And at that time, the concept was that by bringing patients to the hospital, we are going to expose them to COVID-19, and if they catch that, the mortality is going to be high, quite high. Then there were workforce issues. We didn't have enough workforce to cover every area. So the most important part of that time, stage was to direct all available workforce towards emergency. And that's why we had to stop elective and go towards emergency. Even the surgeons were covering ITU, and they went into different type of rotas. There were guidelines issued by colleges at that time that we might be, as professionals, asked to work in the specialties which are not our normal specialties, but in these circumstances, you're covered for that. So I think everything changed with that. And then the issue was capacity. There was a big worry that NHS might not be able to cope with the number of cases which are going to come in. And that is why we wanted to divert all our resources towards dealing with COVID-19 rather than doing elective work at that stage. So these were the different factors. If you remember, there was a lot said about keeping the curve down or leveling the curve. And that was the main purpose, was because we know there's a limited capacity in our health system, and so that we can cope with it. It's very interesting that at that stage, professionals took the decision themselves. But now, recently on 29th of May, there was an article published in Lancet, which actually looked at worldwide 1,128 patients, and out of which there were emergencies elective. And even they came up and said clearly that there was about 38% mortality. And those who had developed respiratory complications, the mortality went above 50%. So these were the main reasons why the whole thing was changed at that time. And elective surgery was stopped in UK. But now we're coming to a stage where we had to resume the services. So just got to reverse everything now. So what did was first, there was different factors we had to look for. So the most important one was first that we wanted to make sure that the COVID infection rates are down. And if you must have heard the word R at present, so mainly we're looking at that it's under 1, and that's where we are now. Then the important part was sufficient number of staff available to return to work. As Naseem pointed out, about 20% of NHS staff was actually shielding, those who still are shielding. So it was a question was, do we have enough staff to do the elective work and emergency work? Then there was that you have got enough supply of drugs and equipment. The most important then factor came up was a sufficient PPE, personal protective equipment. I will come back to that bit later on as well. And then also we wanted to make sure there are enough ITU and ICU bed available in order to deal with the patients who are coming with COVID, and also on the top of that, elective surgery. So I'll look at each of these factors now. So the first thing was to have a COVID light hospital. Then I'll come back to the patient preparation, staff protection, and how do we prioritize when we start the surgery again. As Naseem mentioned, there were about more than 2 million cases in UK who were deferred because of COVID. So now trying to bring them back, we need to have some justification. How do we prioritize patients? COVID light hospital. What do we mean by COVID light hospital? We call them green hospitals. It was easier in UK because what we are talking about, the hospitals where we are not treating acute COVID emergencies, or we're not taking acute patients coming with a suspected or a proven COVID. In UK, what we did was we had private hospitals. So a lot of private hospitals were taken over by the government of UK, and those hospitals are being used as COVID light hospitals. Then we wanted to make sure that those hospitals got adequate facilities, they've got adequate specialty cover with all critical specialties, and their theatres have got a proper airflow systems in them, because those were vitally important to stop the spread. Patient preparation. Now, how do we make sure that patients who are coming in, they are safe? Because we know that the mortality, if a patient catches COVID pre or during operation or afterwards, is very high. So we made sure that the patients had to self-isolate for 14 days. They should have a negative swab 72 hours prior to the surgery. And then again, they got to have a commitment to stay in isolation for next 14 days, because this is a vital period. Staff protection. That was quite an important factor, because if you see, those of you who've seen the UK figures, we've lost more than 200 healthcare workers. And interesting thing is that we didn't in all of this, there was only one worker healthcare workers from intensive care who lost their life. The reason was because of proper PPE in healthcare environment, and that was mainly ITU where there was a proper PPE at that time. So there was a lot of myths about PPE, but recently there's a very recent article which has been published by NERVTAG, which is a new and emergency respiratory virus threat advisory group, and Scottish government has published their recommendations. On basis of that, PHE, the Public Health England, has modified its recommendations for use of PPE. It's interesting, they looked at it, aerosol producing procedures. It's mainly the evidence, strong evidence is in favor of procedures which are performed on oropharynx, like intubations and nasal or pharyngeal procedures done by ENT. And the other one was upper GI endoscopies, where there's sucking involved, quite a lot of it. So, but on the other hand, there was very little evidence to show that laparoscopy disposes to spread of these viruses. So I think the guidelines have changed accordingly now. Then it was risk assessment of the staff itself. We know that about 70% of the staff who passed away during the COVID crisis, who lost their lives in the line of duty, were from Black and ethnic community. So there's a risk assessment of staff, which is mandatory for every organization to do it now. Then it was that we wanted to make sure there are allocated trained staff in theaters, because when you are wearing all this PPE, it's very difficult to communicate. I'll show you some photographs at the end of it. And what we want to make sure is that the workforce is properly equipped and is able to do it. And as Naseem said earlier, most of the surgery was being done by seniors, people who got experience. That does have implication, and I think we could to some stage discuss that, of the training of the junior doctors now. Then came prioritization, because if you know, there is in NHS, there's a waiting list, especially my colleagues from UK can understand it. So we had to decide, how do we prioritize? So prioritization was done on these lines. I'll just give you some example. The first one, emergency operation needed was 24 hours, is quite clear, and that is emergency procedures requiring laparotomy for ischemia or for peritonitis. Then 1B, or bowel obstruction, which could be prepared in 72 hours and then could be dealt with. So that goes in there. Within 1 month, our people like who got a Crohn's stricture, requires surgery, could be done within 1 month. And then MDT directed breast cancer was following in that, and MDT directed pancreatic and esophagogastric cancers. Then comes level 3, which is within 3 months. In that, you still got MDT directed colorectal cancer, as well as someone who is presented with pancreatitis and gallstones needs laparoscopic cholecystectomy. And then you can put rest of the patients into the group. Legal problems. Now, it's very important. We need to make sure patients understand that there is a risk of them catching COVID, because legal issues, legality or responsibility doesn't change with this. So we have to inform the patient. Recently, the BOMS, which is a Metabolic Society of UK, has issued a consent form, which patients have to sign and send it back. And they've got to give commitment of 14 days isolation pre-surgery and 14 days isolation post-surgery. And there are also, we need to cover, because we are making changes in our fundamental pathways, the procedures which we are doing tomorrow, now we are postponing them for a month or 2 months onwards. So I think we need to be clear about those things. Post-operative care, this operation doesn't end with surgery. Post-operative care is vitally important. So we need to make sure patients understand what sort of care they're going to have afterwards, who's going to be looking after them, and where they're going to be looked after, and make sure they haven't got someone in their house who's shielding, because they are a risk themselves. So I think those factors got to be looked into it. Also, if these patients are readmitted, which environment they will come into, and how they're going to be looked after. So these were all the important factors we had to address before we moved on to starting elective surgery. And just a couple of photographs here to just see and lighten the mood a bit. This is the new era we are into. I'm doing my outpatient clinic sitting in the garden, and also this is my theater equipment, and that's what I said about conversation with the staff is difficult with it. Thank you very much. I will take questions at the end. So thanks for joining me, and stay safe. Thanks, Sadaf.
Thank you, Mr. Amir Khan. That was an excellent talk. Like we said earlier, we are going to take questions at the end, so please keep posting your questions in our chat box. I will pass on to my co-moderator, Mr. Sawal, to introduce our next speakers.
Thank you very much, Sadaf. And so far, there's excellent talks. Our third speaker, Mr. Yusuf Iftikhar, who is also a consultant surgeon, associate professor, Royal Derby NHS Hospital in UK. And Mr. Iftikhar is talking about a very important group of the patient, which is the cancer patient. And now his talk title is Impact of COVID-19 on Cancer Surgery. Mr. Iftikhar. Sir, Mr. Iftikhar, can you hear me, sir?
We just need to unmute Mr.
Unmute yourself, sir.
I'm just trying to unmute Mr. Iftikhar. Just bear with me. I'm just taking a bit slow on this end. Just bear with me. Yep, should be okay now.
Okay, can you hear me now?
Yes, you can.
Yeah. First of all, many thanks to Sadaf Jafarbai and Afzal Sawal. You are conducting it very, very well. Thanks for introducing me as well and giving me the opportunity to talk to you guys. Very eloquent talks by Naseem Wadais and Amir Khan, and they've covered most things about COVID surgery. However, as you can see that I'm going to talk about cancer surgery in COVID, during and post. What did we do? Now, all of a sudden, in early March, everything was stopped. We press the button to cancel every elective work completely. Nothing happened. My last list was 13th of March, and I did laparoscopy that day, and fortunately, I used N95 mask and cover. But thereafter, nothing happened, and the specialties which were suffering were upper GI, endoscopy services, 2-week wait. For those people who are listening from abroad, in UK, we have got a system of 2-week wait where patients, if referred for suspected cancer by the GP, they have to be endoscoped or screened or have a CT done within 2 weeks. So all the endoscopies had to stop, so 2-week wait went out of the window. Breast surgery was fortunately not stopped and was done in green hospitals, which were the private hospitals. The NHS hospitals were receiving the COVID patients while breast surgery was done in private sector. Private sector was taken over by NHS. Gynecology suffered, oncology, gynecology, oncology, ENT and max fax. I lost a colleague of mine, ENT consultant here, because ENT, they look into throat and mouth very closely. So contamination and transmission of virus in those subjects who were involved in that sort of work was very great. So they stopped it. Colorectal surgery stopped. Hematology and oncology. Hematology, oncology did not stop per se because the oncologists carried on giving chemotherapy and all that, and that was very good. Therefore, we were in a situation where there was a great impact on the surgical services, and we had to wrestle with the idea of providing no care, some care, or full care. And where did we move in 3 months' time? We moved on to looking at the data which was available. Although Amir has already touched on this subject, and this paper everybody talks about this paper now because this was the seminal paper published on this subject of mortality in surgical cases. 7 days before or 30 days after surgery. That was the criteria of inclusion in this study. And mortality was very high, 23.8% cases, i.e. 268 cases of 1,128 patients actually died. 577 had pulmonary complications. So people who died, 82% of those died because of pulmonary complication. We were not in a position to do elective work or cancer work because cancer patients were shielded as well. So if we try to do cancer work in these patients, they will acquire COVID and they may die, which was not acceptable. Government was saying all sorts of things like this access to a cutting edge treatment and all that, but they did one good thing. They pushed the nation to stay alert. That means very little to me. But what it meant was to stay at home. And this nation, for sure, listened to the government edict and they stayed home. They stayed home for 3 months. And not surprisingly, R, which is the infection rate, remained below 1. You can see it on the left hand of the graph. The 1 is written on there. And the infection rate stayed below 1, between 0.7 and 0.9. Therefore, the load on the NHS went down. The first opportunity which the nation got of a good weekend, white people, they get attracted to light like a moth. And you can see on this beach, in Bournemouth Beach, hundreds and thousands of people are there. Similarly, we had unfortunate incidents of Black Lives Matters issue, and lots of black people came out on the street as well. And what impact these two incidences will have on the rate of infection and will there be a second wave or not, that remains to be seen. However, as regard to cancer surgery, we couldn't do a staging laparoscopy, we couldn't do endoluminal ultrasound, we couldn't do ERCP, so we were stuck. And that covered, the laparoscopy covered gynae and colorectal as well as upper GI. Why did we not do this laparoscopy? Because this paper really talks about it very, very well. It discusses that when we use devices which produce plume, electrocautery, laser or ultrasound and scalpel, it can cause viral transmission, because as Naseem in the very first talk mentioned that 29% virus were found in the feces of those patients. So there is a virus in gastrointestinal mucosa as well. So there could be a transcelomic transmission, but it really is not true. That was totally unfounded because the evidence was not there in the literature. There's only one study which really talks about hepatitis B virus transmission, and what they found was that in 11 cases, they detected virus in the plume. But never again, no other study has been done which will look at in vivo effect of the viruses found in the plume. Are they truly infective or not? So we don't know. But safe thing was to stop laparoscopy and don't do it. Therefore, we had to develop techniques which will protect us, which will protect the staff, which will protect the patient as well. This was a war-like situation. In every war, we have learned lots and lots of things. The majority of surgical developments have come as a consequence of the war. I was one of the first ones to actually fit test an N95 mask and this gown. Then now things have moved on. We now have respirators. Amir has shown us one of his photographs sitting in the garden, and next to it is his theater attire. And that is this sort of respirator, which doesn't require mask. But this mask actually works far better in my view. In my case, it's fully safe, fully protective, and you can only use cover, and that works. Great innovation happened just before the COVID came in, was this air seal. Air seal has got gas going in and gas coming out. So temperature is maintained, pressure is maintained, view is very good, and there is suction attached which doesn't leak out anywhere. So this machine actually provides you a fantastic laparoscopic environment to work in and protects you as well. Now, as regard to cancer surgery, I wouldn't go into the detail of consenting and all that. Amir has already touched on that subject in great detail. Once you have all done that, identified the individual who needs surgery, we have commenced surgery already. What we do is that we test them like on day one. If they are COVID negative, we isolate them for 14 days, and we trust them that they will be isolating themselves at home. Then we'll test them again fortnight later, and if that is negative again, we go on and operate with full protection and all that. The patients who are positive, we would give them a fortnight and we'll test them again. If they are negative, then 3 days later, we will operate on them. If they are positive, which some of the cases may remain positive for a long time, but are they truly positive or not? That is the discussion which is we are having at the moment. Are these viral particulates which are actually showing you the presence in the test, or they are true active viruses? We don't know. So that is something which we have to come to terms with and learn and evaluate and implement in future. We here in my hospital, we have done 109 cases up till now. And there's only one case which became COVID positive, and thankfully he has survived as well. There were 3 vascular cases during the emergency time that there was a problem, but in the elective cases, since we have started doing our cancer work, there's been no problem whatsoever. Thanks for listening.
Thank you very much, Mr. Iftikhar. As you well known as the Iftibai. Thank you very much, sir. And me as a pediatrician, I'm learning a lot, even being a non-surgical person. So that's very useful. I hope that's very useful to all of our listeners. I'm very pleased to announce our next speaker, Professor Fazl Ali Khan. He's a professor of surgery in Rashid Latif Medical College, Lahore, which is a great city, and I always love to visit Lahore whenever I used to go to Pakistan. I'm sure there are many challenges in this COVID-19 situation in Lahore. And Professor Fazl is going to talk to us about the challenges in surgery he faced and perspective of surgery in COVID-19 situation, especially in Pakistan. To Professor Fazl.
Thank you, Dr.
Before we come in, Professor Fazl, before you go any further, I would request Mr. Syed Iftikhar to please stop sharing his screen. Thank you. Please carry on, Professor Fazal.
Thank you, Dr. Afzal Sawal, Dr. Amir Bani, Dr. Sadaf Jafar Boy, and other panelists. It was really very enlightening to hear from the eminent surgeons from UK, and I would like to share our experience of this deadly virus. I will start my presentation. Just a minute. Okay, so we had certain challenges even prior to this pandemic, and the important barriers, as are known to all of you, to provide quality healthcare, we have always been resource constrained because of economy, because of the skills, and because of lack of literacy rate. To top up, we have certain degree of malgovernance, negligence at every level, and lack of accountability does not allow us to learn from our mistakes. We have a very fragile supply chain system in place, and whenever there is acute need of certain medicine, it gets very difficult to acquire that. Of course, there are islands of excellence in this sea of mediocrity. So to combat COVID-19, we started with a huge disadvantage.
Dr. if you can kindly put it on the slideshow, please, if it will be
okay,
better demonstrated.
So when we learned about this problem in Wuhan, we thought it's a Chinese problem. And we continued merrily with our activities, and this PSL matches attracted huge crowds. And this was a phase of complacence. Then there was a rude awakening when there were pilgrims from Iran who returned, and there were chaotic scenes at the border. And then we had COVID-invested Pakistanis coming from Europe and Middle East. And then we didn't know what to do with them. We stayed in a state of confusion, and then suddenly, when the cases increased, then lockdown was announced. Again, there was no consensus on how to do it, how effective to do. So we gave confusing signals to our masses. Even in lockdown, adequate preparations were not made to deal with the cases once we eased the lockdown. Because of economic situation, we thought that it cannot be continued indefinitely. There were many myths, conspiracy theories, political point scoring, and these raised false hopes and fears, and all culminated in blame game and anger. As a result, the kind of respect and kind of trust that NHS had, unfortunately, our health delivery system did not have that. And when the patients did not see the facilities on ground, they were very angry with the doctors. And when there was a fatality, they thought it was the negligence of the doctor. Pakistani hospitals were struggling and are still struggling with coronavirus explosion. Country sees multiple consecutive days with record cases and deaths as overworked doctors plead for breathing space. Media in both social and mainstream did not play a very positive role. The hallmark of their presentations was sensationalism, irresponsible reporting, and biased reporting. And instead of highlighting the care that people should take, they were highlighting the faults in the system. The threat to healthcare workers was not only from virus, but also from angry mobs. And in KPK, there were 20 attacks on medical workers. And this was because when the public came with the idea that everything is going to be available for them when they need it, and when they reached hospital, they found there was very little for them. Now, I will talk about the emergency surgery during COVID-19. Initially, we continued as usual. Lockdown and fear of corona led to delayed presentation in more critical conditions. Incidents of COVID infection and deaths in healthcare workers demoralized doctors. There were not enough PPE, there were not enough guidance available. And suddenly, surgeons thought they have to fend for themselves, and they start looking for guidelines from abroad. Improvised and inappropriate application of these guidelines and pathways and fear resulted in deaths in many non-COVID acute abdominal trauma cases in public sector hospitals. When they needed surgery, they were referred for screening and referred to medical ward and corona ward, and ultimately dying of sepsis. Many dedicated diagnostic centers were closed. The endoscopic facility remained unavailable for weeks, and then there was limited availability. PCR facility for screening was only available in major cities, and it was rationed. Only those who could afford to get privately done were able to get it done when they needed. Others had a certain criteria to fulfill, which many of them did not, in spite of the symptoms they had. Now, as surgeons, we try to improvise care of urgent and non-cancer surgery by doing more percutaneous procedures. For example, in acute cholecystitis, of image-guided cholecystomy, stenting of CBD vendors was available. Because of fear of aerosol generation, we avoided general anesthesia wherever it was available and used regional anesthesia instead. And we started doing pre-operative screening of our patients, and the patient wait for 24 hours to 48 hours before screening became available. But now we get screening results within 12 hours. And then we realize the importance of perioperative isolation as if
Sorry, Amir, I think we lost Professor Fazal.
Yep, so we'll wait for Professor Fazal to log back in. I think we've lost his connection. So if Mr. Amir Khan is listening in, could you kindly get in touch with Professor Fazal and see what's happened at their end?
Okay, in the meantime, I suppose so far, whatever Mr. Fazal was, Professor Fazal was been telling us is really eye-opening how the COVID-19 situation is being dealt in Pakistan, where the resources are limited. There's a lot of myths and a lot of conspiracy theories and a lot of other issues involved in the management of the managing in these patients. And one of the most worrying thing is that many of the health workers was being attacked by the mob and the patients, which is really frightening and worrying situation in our country. I'm sure they come to the hospital with all the expectation. If they found that their expectations are not being met in the hospital, they get very frustrated, and I'm not surprised. Okay, we are waiting for Professor Fazal to enlighten us more on the situation. Thank you very much. You're back, sir.
Just wait, Professor Fazal, I'll have to unmute you, so just bear with me, sir. You have, I can't see Professor Fazal's name on the list. Professor Fazal, have you joined with a different name? Please type in your name in the chat box with the ID you joined in, so we can unmute you, please. Thank you. Professor Fazal, would you please say a few words?
I can hear you.
That's fine.
Yeah.
Please carry on, sir.
Carry on.
Thank you very much.
I can hear you. Can you hear me?
We can.
Yes, we can.
Please carry on.
Okay. So, okay, so regarding cancer surgery, it was continued initially while certain specialties were suspended. Shaukat Khanum Memorial Trust Hospital stopped taking cancer patients for 2 weeks and then restarted limited services and eventually full services. GI services were suspended for 4 weeks. PKLI Kidney and Liver Specialist Hospital was converted to Corona Hospital. They stopped doing our liver and kidney surgical work. CMHs all across Pakistan stopped taking
I think again we some technical issue at Professor Abdul Fazal's end. So let's wait for 30 seconds or so and let them reconnect.
While in that 30 seconds, we're going to keep discussing. If there's any question, please writing down in the chat box. We will going to be answering at the end of the sessions. And we try our best to be finishing on time. So far we have few questions coming up.
Yeah, we have lost Dr. Abdul Fazal for the time being, so he's going to log in.
Shall we go on to some of the questions we take on, and we'll keep discussing. Otherwise, we're going to see each other and not talking. One of the
So,
Mr. Jamil,
I'll start
can
with
you
the
hear
first
me?
one, if that's all right.
Yeah, start.
So this is a question from Dr. Saqib Ghani. It's already been addressed in the chat box, but in the interest of rest of the participants, I would request Mr. Amir Khan to answer this question. The question is, how long do patients need to be self-isolating before and after an elective surgery?
Thank you.
Before you go any further, I think Mr. Fazal is back online. So I'm just trying to unmute him. So let's see if we can unmute him. Mr. Fazal, can you hear us?
I can hear you clearly.
Please carry on. We keep losing the signal from your end. If you would like to carry on with your presentation.
Okay. Okay, so we were discussing that cancer surgery initially continued in some of the hospitals and in certain specialities, while Shaukat Khanum Memorial Hospital, PKLI, they stopped for a while. Actually, PKLI is not doing any surgery now. All CMHs all across Pakistan stopped taking civilian patients. Certain departments completely withdrew service like oncology in certain public hospitals. But in other hospitals, they continued. More patients are now being referred for new adjuvant radiotherapy. We have very limited radiotherapy facilities, and usually there's a very long waiting time. So we need to adjust our fractions so that we can accommodate more and more patients. Where feasible, new adjuvant chemotherapy was recommended, and those already on new adjuvant chemotherapy were advised additional courses. Regarding elective non-cancer surgery, public hospitals stopped all elective surgeries as in UK. Private hospitals continue as long as they felt safe, and then they stopped when they thought it is risky. There was shift to regional anesthesia wherever possible. Actually, public became quite afraid of visiting hospitals because of fear, so attendance for elective non-cancer surgery has been reduced substantially. Screening, isolation, and additional infection prevention measures may increase, they mean increased cost of treatment as well. So it's also that cost of treatment has also gone up. Restarting cancer elective cancer surgery resumption should be the first priority. Most of the surgeons are now preparing to start elective cancer surgery as soon as it is safe. It is only possible if transmission of COVID is reduced. Educating patient and family for the need of pre-isolation, screening, and post-operative isolation is of paramount importance for the safety of the patient. And as Dr. Amir Khan mentioned, creating green facilities for non-COVID patient is important to restore the faith of the patient and allay their fear that they might get COVID infection when they go to the hospital. So better protection of healthcare workers from COVID-19 will also help. The prioritization that we need to do is to improve our operating infrastructure, make available most effective PPE for healthcare workers and train them to use these effectively, rehabilitate and restore strength of anesthesia department, which has been weakened. We had a lot of incidents of COVID infection in anesthetists in Pakistan. With so much leftover cases, we need to screen ones which need downstaging and where we can go and proceed to surgery right away. The conclusion which I can draw from these observations are that already inadequate healthcare service in Pakistan has been further compromised. Patient turn-up has sharply declined, partly because of fear, because of lockdown and lack of mobility, and also loss of earning. Most of the people are daily wage earners. We don't have much social security. Healthcare cost has increased, further limiting affordability. Many of the cancers have been upstaged, and it means they are no longer resectable. We should develop separate COVID-19 and non-COVID-19 facilities to reduce fear of patient and healthcare workers and reduce the transmission of infection while they are in the hospital. I think we need to invest more in healthcare delivery and to improve supply chain as well. With the economy going in recession, it appears a stiff challenge. So I conclude my presentation here, and questions will be asked whenever you want.
Thank you very much, Professor Fazal. That's a quite enlightening presentation. When the economy is in recessions, and the country like us who were socially deprived and the lot of challenges, I'm sure you people are doing great job in this stressful situation of COVID-19. Obviously, if there's any question, we will going to take on in the end. Thank you very much. And to Amir Bernie, if you want to make any announcement before we start questioning.
Thank you so much to everybody for doing the presentations. I just wanted to remind everybody that we are also on Facebook Live and on Facebook Messenger, and we will be taking questions from Facebook Live and Messenger. We are also recording, so if anybody has any objections to being on camera, they can obviously put their cameras on off and their audio on mute. I will pass back to Sadaf and Saul Saab for taking questions.
Okay, so I'll start with the first one. It's a question for Mr. Amir Khan from Dr. Saqib Ghani. How many days are patients asked to self-isolate prior to elective surgery? Is this a standard used across UK, or different trusts are using different time duration?
Thanks very much, Sadaf, I'll answer the question. I'll also take a bit of privilege being in a panel, and I've got two questions to panelists. Can I put that as well, if you allow me, please?
Yes, please. Yes.
That'll help people. First thing, yes, Saqib, thank you very much for joining us. Yes, the recommendation from the colleges are very clear and is being implemented in all elective settings now. that the patients are being asked to isolate for 14 days pre-op, 14 days post-op, and they are done a test done 48 hours in advance. In addition to that, in most of the COVID light hospitals now, all the staff is being asked to be regularly swabbed. Like our local hospital, which is a COVID light, the private unit, they are doing twice a week now, swabbing for healthcare staff as well. Right, coming to the two questions. One, I've got a question to Iftikhar, and the other one is to Professor Fazal. Iftikhar, would you please help us just on a question about endoscopy, upper and lower GI, where we are with it and what are the risks? Professor Fazal, the question is that most of the private hospitals, the way the COVID has hit, elective surgery was stopped. What's happening? Are those hospitals viable now, or what's going to be the future of that private health sector in Pakistan on that one? And just one comment for people, there's a lot of things about PPE. Guys, I would recommend you strongly go on to internet, read the study done by NERVTAG, NERVTAG. They have assessed all procedures, the data available so far, and it does actually take away a lot of myths about PPE. So please do have a look at that. Thank you very much.
Thank you. To Iftibai and Professor Fazal then.
Yeah, Amir, thank you very much. Thanks for asking that question about endoscopy. When we commenced endoscopy sessions, we started using full PPE. We started using the hood and N95 mask. However, as I've already shown you the pictures, the new hoods are even with the respirator that should be used for endoscopies. Naseem wrote something on the sideline that they use gloves and gown. I didn't mention that in my response in the chat. It is mandatory. Gloves and gowns are always there, and we use it even when we didn't have COVID. So gloves and gowns and mask and the shield is important for endoscopies, of all sorts of endoscopies.
Professor Fazal, are you with us, sir?
Yeah, unmute him, please.
Yeah, we have tried. Just a sec. It's just taking a bit longer than usual. Just bear with me. Yes, please.
Okay, so the Amir Khan asked about the viability with the reduced number of operations being done in private hospitals. There is a government facility of loan at a very low interest rate. Government gives loan at 3%, and we can pay our employees will be paid by the bank. So we will not get the salary, and we will not reimburse to our doctors, but instead the government is going to pay during this period. So salaries is one major expense of private hospitals, about 40–50% cost. So that facility is there. So in that way, the viability is becoming possible. The other thing is that certain facilities are continuing, like birthing facility, obstetric services, and the private hospital where I am working, it's mostly doing cesarean section or deliveries, which have to continue. And now the other source of revenue is treating the COVID patients. As the government facility is insufficient, and some of the patients who want better care, private sector is providing COVID facility. And that is the place where a lot of blame is coming as well, because the charges for these services are quite high. I can share with you that on average it costs 30,000 to 35,000 to pay for the medical officers, hygienists, respiratory technicians, and the consultants. So this is on top of the normal routine room charges. So the care of COVID patient is really expensive, but that is another source of revenue to make up for the lost revenue in elective surgeries.
Thank you for that, Professor Fazal. I'm going to move on to the next question, which is to Mr. Varaj. And it's a question regarding COVID positive patients. If they've had major surgery, did they require ITU or HDU care?
So I've tried to answer in the chat box. Once the patient, can you hear me?
Yes, thank you.
So once the surgery is done and patient is COVID negative after one test, the norm was they were used to discharge back to the nursing or care. But we need to keep in mind that 1 in 3 swabs are false negative. And that's where the problem happened when the patient got discharged nursing home or care. The mortality increased in those areas as well and after contacting the positivity. So there is no clear evidence or guidelines in such case. It has to be a symptomatic free and obviously the isolating period, incubation period of 2 weeks. And after that, you can take risk. But one of the pathologists in our hospital has mentioned some cases have been even positive after 60 days after contacting the COVID-19. So the evidence is evolving or regularly on a regular basis.
Okay.
Thank you very much. Yeah.
Sorry, Dr. Sawal.
Sorry, I missed the question. You asked me where to, sorry, I mixed up the questions. The question was asked where to get discharged, either ITU or in the ward. Yeah. So depending on the severity of surgery, if it's a major surgery, they usually go to ITU. And if it's like appendicectomy or any other minor surgery, then they normally go back to the ward where they come from, which is again an isolated area. So patient normally get to transfer to ITU if they are symptomatic from that particular area. Otherwise, there's no hard, fast rule that every patient after surgery will go to ITU if they are COVID positive.
But of course, you would want to transfer them to an area which is for COVID positive patients.
That's right. Yeah.
If they end up going to the ward.
Thank you. Thank you very much. So our next question came from the Irfan Akhtar. He's also a surgeon himself. A big concern with the mechanical ventilator is communicating with your assistant. How is your experience been to Amir Khan and Iftikhar Bhai?
If I may add on to that, I mean, I probably put in more. One of the concerns as we started doing more and more of laparoscopic work, and that is where you need your assistants to move the camera around, or even for other operations. The hood has limited the communications and being understood quickly and precisely. That has been raised, and we are now investing into some microphones. Is that an experience with you guys, or how have you tackled that?
Right.
And I may add on that it doesn't help if you are Welsh or Scottish.
Okay. Thanks very much, Irfan. Actually, I'm going to answer the question, but then I've got a question for you as well, which has come from the audience as well. I think as far as that's one of the reasons I stressed when we talked about the team. It is a practical problem when you're wearing a hood to communicate with people properly. So you need a proper team. You need the team which is you're used to. You need assistants who are used to, the nurses who understand the procedure. You can't just do it with everyone. So I think you have to have those in place unless until you can start using microphones or talk to each other. But it is difficult to communicate with the hoods. It is true. That's a practical point. Can I ask you a question now here? There's a question put by one of our questioner audience is that the surgeon who has, because you don't mind me saying, it's mainly to do with surgeon who is recovered from COVID, their return back to work and the risks. Please.
Yeah, so no, I don't mind a question at all. I think it's no more a secret. Yes, it's a challenge. It is a challenge on many fronts. Firstly, your personal front, and then the service itself. It doesn't help that if you were one of those who were doing a special procedure which there are not many alternatives around. So the service does get affected. As probably you or Iftibai said, that the good thing about that was that the surgery halted, and pretty much all elective work was stopped for up till the 1st of July. So what has resulted is that maybe we mitigated at that time in absence, but then the pile up is building up and up and up. The second bit is your own personal, recovery plan, and it is extremely bizarre the effects of COVID on various people. Alhamdulillah, I'm doing pretty all right, and I'm planning to start hopefully next month or a month after. But there are people who have got strong post-ITU symptoms which are still prevailing, and they need a long rehabilitation. And this not only picks up the time when you are at your recuperative phase, but also the phase return, which will follow gradually to come up back to your speed where you were. So I think it's going to be a big challenge for NHS as we progress. I am not including the mental health part of that thing, which is affecting a lot of colleagues, even though they did not have a very severe disease, but they still suffered a lot. So COVID has been a mystery, remains a mystery, and its effects on various people are protean, and it kind of baffles you.
Irfan, can I just, the thing is that there is now, we know the studies have shown that although you could be antibody positive, but that does not give you immunity against the disease. So the risk about reinfection with this one, I'm sure, is there something more for an audience to understand about that?
Yeah, so the last survey, which was done by the Royal College of Physicians, is that the total workforce, although we have only done about 38 or 40% of them, 10% of those turned out to be positive. So 90% of people are still negative to antibody test, whatever it means. That kind of counter argues the fact that whatever we were using, good or bad, accounting PPE, because there have been lots of questions about PPE, it was working, because only 10% have got positivity, 90% still remain negative. It's a very, very important factor to keep in mind when we start calculating about PPE. Time would tell, Amir Bhai, that whether this positivity, I'm going for my plasma donation next week, so we are giving it as we go along, whether it has got a long, I think there was a very nice article presented by the New York Hospital Consortium saying that 23% of all the New York population who were positive with COVID test had actually IgGs enough to be called therapeutic effect range. So I don't know what would be the outcome, because the recovery trial hasn't come up with an answer for that question.
Okay, thank you very much, Irfan. The next two questions I was going to put to Mr. Iftikhar. One is, he can talk about the communication with the assistants, and also second, somebody asking that what he thinks delay in the management of cancer cases with a significant impact in the prognosis of that cancer, please.
Thanks, Afzal. And I read those questions, and I'm delighted to be answering it. First thing, when we started our theatre setup with the hood and everything, Irfan brought this up. Indeed, it was difficult. The hood was hitting your assistant. If you had more than one assistant, then it was nightmare. The light wouldn't go into the wound, and so on and so forth. What we have done now is that we actually use the communication wireless system. We put it inside the hood and we talk, because otherwise we were writing on a piece of paper, a sterile paper, as to what we want. We were showing it to the nurse that I want a scalpel now, I want a suture now, and it wasn't working very well. It was a lot of a struggle, because you got very tired as a surgeon as well, within the mask and hood and everything. Now the second question was, Saul, what was the second one we asked?
I mean, what's the impact on the cancer patient?
Cancer patient, yes. Now, we had difficulty. When I put a slide up, that the impact was enormous, and we were wrestling with the issue as to how best we can manage it. What we did was that the number of new adjuvant treatment available for these patients. Some of them get 3-cycle chemotherapy to start with, then surgery. There are other trials, and out of trial as well, 4 cycles of chemotherapy. So we actually started giving people fourth cycle. And so that will buy us time. And so hopefully that will not have any adverse outcome of care on these patients. But I'm quite certain that some of the people have suffered. The disease doesn't wait for you. And if you don't treat upper GI cancer, which I normally do, if you don't treat them, majority of them will no longer be with us more than 6 months or 9 months. So they progress very rapidly. If you don't give chemotherapy or surgery, so I'm sure there will be an impact. And that question was asked by Harun Javed Majid. Harun Saab, if you are listening to this, the answer is that indeed, in the long term, you will realize that there was some adverse effect because of this.
Thank you very much.
Okay, the next question is from Mr. Shabi Ahmed. Yeah, I know Mr. Ahmed himself is a consultant urologist, and the question is for Mr. Iftikhar, Mr. Waraj, and Professor Abul Fazl. It's a question: are the GI surgeons resuming upper and lower GI endoscopies? And what is the level of PPE used? And is virtual colonoscopy an alternate option?
I've already answered this before in a question answer before. Somebody else has asked colonoscopy, gastroscopy. Yes, we are covering ourselves and protecting ourselves in every possible way. Irfan has already mentioned that those people who were protecting themselves, the infection rate in them was very low. And in the chat box, it was highlighted that of the 340 healthcare workers who have died, there was one ITU consultant, and there were 2 or 3 ITU nurses, and the percentage was very low. Because they were protecting. The PPE available in ITU was the best available in a hospital as compared to A&E and all that. So
thank you, Mr. Iftikhar. Mr. Waraj, is virtual colonoscopy an alternate option?
Yes, initially when we started, just to reply Shabi's question for PPE, as a colonoscope, lower GI surgeon, we have resumed the colonoscopy services, but again with full PPE, FFP3 mask, shielding, double gloving, not single one, double gloving and gowning, and also the time between the two phases to clean the area. That's for the endoscopic purpose. And you're asking about the virtual CT scan, virtual colonoscopy, which is again a CT scan and require full bowel prep. That depends on your local resources available. In some centers you can't do it, and other centers they got full facility to do it. It is again highly contagious procedure, and they have to take full precautions in the CT scan area. As we just found out, that 30% of people do have fecal-oral contamination. So initially it was stopped in our hospital in the beginning, and then restarted halfway through when the curve was started flattening out. So yes, it is a viable alternative for excluding the cancers, lower GI cancers.
Thank you. Professor Fazl, what is the situation with virtual colonoscopy in Pakistan?
It has got a very limited availability. The other thing is that endoscopic services have restarted with proper PPE. So endoscopy is available, and virtual colonoscopy is available in very limited places.
Thank you.
Okay, thank you very much. I think the next question to be asking about the PPE, if due to certain reason, if the mask does not fit very well to the face because of the beard or the shape of the face, what would be the alternative to any person who has got beard, Amir Khan sir?
He's muted.
Great. I think it was a big issue with FFP3 masks because if you got a beard, and like mine was okay because it's short, so I can go across it. Otherwise, because the exchange from outside air doesn't stop, so you had to. A lot of people had to shave because of that. Hoods are okay if you can fit your beard within a hood, but if you got a very large beard, you might not even fit in the hood. So that is a practical problem, and there isn't an easy answer to that. Either they change their fields or do something different, but it isn't an easy answer. Can I take an advantage and ask a question from Sadaf? Sadaf, being a breast surgeon, Could you please just tell us the management of breast cancer during this period?
So we use the same prioritization categories as you had mentioned in your talk. There were no category 1s because we don't do emergency cancer work. Category 2 were the triple negatives or HER2 positive cancers, or the ones who had neoadjuvant chemotherapy and awaiting surgery. So those were the patients we carried on operating on them. Whereas with the ER positive small cancers, most of which were screen detected, we had put them on neoadjuvant hormones. This is right back in March. But now as services have started to resume, we are calling these patients back and we are now operating on them. With regards to oncoplastic work, back in March and April, we weren't doing any reconstructions, but now we have selectively started offering that services.
Because the changes you made by putting people on adjuvant because you couldn't operate on them, are you going to look at that data and compare with the survival of the ones you normally just go with the normal management?
So this is an ongoing national audit about breast cancer management. So, in 6 months, 12 months time, we will know what is happening to them. But I have to say, having operated on a couple of patients, particularly the ones who were node positive, we haven't seen much response. In fact, the ones that the DCIS went quite low down on the list. And I have to say, having operated on a couple of DCIS patients, we have found an incidental finding of an invasive component, which has been HER2 negative. So certainly, there has been a bit of a delay, but hopefully in terms of systemic treatment, they shouldn't come to any harm.
Thank you.
Thank you. Thank you very much, Sadaf. The next question is very interesting. It's because all we are having nowadays about antibody testing, and the positive rate is very low. Is about, somebody mentioned for the Abisab is only 10%. The question is that what conclusion we draw from it. That means is that there's no herd immunity, and we all should be wearing appropriate PPE. But I want the opinion of other panelists about this, because we haven't got antibodies against this COVID-19. So what's a surgeon will going to do in this situation?
I think we need to learn to live with it. I think we need to make sure we take all precautions. The message should be the disease hasn't gone away. The disease is still there. And I think one of the good things which has come up with, the positive thing which has come out with COVID is that prior to that, we were not taking as many precautions in our theaters and other places. Now I think we have to, and make sure that we protect our patients, we protect our staff, and protect ourselves. That's the only message I can give you.
Thank you.
Okay. The next question is for Mr. Amir Khan. During the acute phase, a number of hospital staff were struggling with the pandemic, with some of them being carers for parents and have disabled children who had comorbid problems. What was the support provided by hospital or trust, and is there a protocol now in place on reflection?
I think we learned a lot out of it, to be honest with you, and very reason that we've lost over 200 workers, healthcare workers, is obvious that we didn't know much about the disease itself, and we've learned as we've gone forward. There are lots of people who are shielding. One of the reasons stopping all elective activity was because of staff being shielded, either because they had their own health issues or they had a family where they're looking after or carers for someone. So I think it's been an important part when we brought people back, when we're starting elective work, that we are making sure that we got enough staff to do elective as well as emergency, because emergencies still take a priority.
Thank you. Being a pediatrician, I want to just brought in a slightly different question to Professor Fazal, if it's possible. Has any experience of doing surgery in children? What's your experience in Pakistan in this COVID-19 situation?
Actually, I don't have any experience of dealing with the children. As young adults, I have dealt with appendicitis. I've done few cases, but not many pediatric surgery.
Okay, fine. Thank you, sir.
I think Mr. Iftikhar wants to make a comment.
No, I'm all right. This has been answered.
Okay, great.
Thank you. We hope we have answered all the questions that have come through in the chat box. But in case if your question has been missed, and I apologize for that, Can I request you to send the question by email to us, and I will direct it to our speakers. The email address to send the question is education@appne.uk. And before we close the session, I would want to make an announcement for our next upcoming webinars. So we've got a webinar lined up for the 4th of July, which is for young junior doctors who want to apply for psychiatry training. And we've got another webinar lined up for the Yaran Watan series on the 12th of July, which is on cardiorespiratory issues and COVID-19. It'll be the same time, which is 11 o'clock British Standard Time or British Summer Time, and 3 o'clock Pakistani time. I will pass on to our President, Dr. Amir Birnie, for closing remarks, please.
Thank you very much to all of you.
Thank you, Sadaf, and thank you, Dr. Afzal. I must first thank our panelists, Mr. Varaj, Mr. Amir Khan, Mr. Abu Fazl, and Mr. Yusuf Iftihar for taking out the time and being part of the webinars today. Thank you to all participants who have taken out their time and to join us from Pakistan, Republic of Ireland, England, UK, other countries. So thank you all for joining in. On behalf of APPNE and as President of APPNE, I would like to thank the team of Yaran Watan, the team leader, Mr. Usman Mushtaq, Mr. Mohammed Bilal, who have been very helpful for us, and also His Excellency Dr. Zafar Mirza, the Special Advisor to the Prime Minister on Health, for his support and recognition of the services and the abilities of the Pakistani overseas diasporas towards this health initiative. So I hope you've all enjoyed this webinar. As Ms. Jafar has already said, we have a few webinars lined up, and we hope to see you at them as well. So thank you, everybody.
Thank you.
Thank you very much. Thank you to all of you.
Thanks, everyone. Thank you. Thanks, Roger.
Thanks, Professor Fadl, for joining us from there.
Great to join from Pakistan. Yes.
Thank you.
Thank you very much, all those who have joined us, especially Abu Fazl. That's very kind of you to join from Lahore.
It was wonderful to be with you.
It was very good to have you here. That's fantastic. Thank you. Thank you, guys.
Thank you.
I think special thanks to the Sadaf and Afzal for conducting it. Fantastic.
Yes, excellent conduction.
That goes without saying. They are part of the family, so that's why we didn't mention it.
Thank you. Thank you. So nice of you. Thank you very much to all of you.
Stay safe, guys.
Thank you. I'm going to stop the recording now.
Stay safe, all of you. Stay safe. Whenever you are.
Recording has been stopped. We will still be on Facebook Live, so just be careful. I'm going to stop Facebook Live as well, stop live stream. So let's stop live.